This is Ryan Vassan for Eyetube's daily coverage. I'm joined today by Dr. Boris Malyugin of Moscow, Russia. Thank you very much, Dr. Malyugin, for joining us.
Pleasure.
And you're here in Chicago at the meeting presenting on surgical tips for coexisting cataract and glaucoma. Can you give us a little synopsis about what you were talking about at the meeting?
Cataract and glaucoma is a very common issue for anterior segment surgeon. So these are basically two categories of patients. The patients with closed angle glaucoma. We know that for this type of glaucoma, it is very common that the anterior segment of the eye is crowded, and actually removing the lens is giving us the favorable anatomical condition of opening the angle and opening the outflow pathways for the aqueous humor. To the contrary, in patients with the open angle glaucoma, we do have some pressure lowering effects after cataract surgery, but usually it does not exceed 1 or 2 millimeters. That's why in these patients we cannot rely solely on cataract surgery. So we have to think about combined approaches in cases when the IOP is very high. And there are a lot of controversies regarding the approaches because actually there are 3 principal ways to go. First way is to do glaucoma surgery and then followed by cataract surgery. The other way is to do cataract surgery. As already mentioned, it's sometimes not the best way. And also you have to decide whether or not doing combined surgery. In combined surgery procedures, there is a lot of variability as well. We can have different procedures combined with phaco. All of them are more or less effective, and in our clinic we do prefer non-penetrating, or we call it non-penetrating. Actually, the international name is deep sclerectomy, because we do think that combination of deep sclerectomy or non-penetrating approach with phaco is very logical, because actually you are created semi-permeable membrane that limits outflow of from the eye, so you have less chance of hypotony in postoperative period, and that is my favorable approach at this particular moment.
And what kind of IOP lowering numbers do you get from that procedure?
Usually we have 6 to 7 millimeters of mercury in the long term.
That's in combination with the cataract surgery?
Yeah, in the combination of cataract surgery. I do remember a very nice paper that was published about I think 10 years ago, and by Freeman and co-authors, and they were trying to find and to search in the literature what approach is better, whether it's better to do combined surgery, what kind of glaucoma component in combined surgery is preferable, comparing to the trabeculectomy, and because trabeculectomy is, of course, is a gold standard. And surprisingly, there was a lot of publications in the literature, over 1,000 at that moment, and only about 150 of them were considered to be reliable from the statistical point of view. And they concluded that actually there is no strong evidence that any procedure is superior in combined surgery. So I'm always keeping that in mind. So, and I'm not pushing my approach because I do think that there are other schools and the other types of approaches. But in my clinic, almost 100% of cases of surgeries in open angle glaucoma, primary open angle glaucoma, is a non-penetrating deep sclerectomy.
So if you have a patient with coexisting glaucoma and cataract, is there anything specific that would lead you towards doing a combined procedure versus one and then waiting for the other?
Of course, there are many factors. When you see the patient, you have to ask yourself a question: what will drive your decision, whether glaucoma is a primary cause of vision loss or whether it's a cataract? in some patients with small pupils and advanced glaucoma, it's not so easy to answer this question. One of my primary drivers is the level of IOP. Of course, when IOP is very high, and even in spite of a couple of medications I use, I will prefer a stepped approach. I will do my decision in favor of the combined approach if the IOP is in the borderline, and when patient is using more than one medication, so that could be a good solution. Also, some surgeons prefer using combined surgeries in patients with more or less compensated IOP, but with the severe damage of optic nerve disc. This is in order to avoid early pressure spikes that happens with phaco alone and in these patients, because even not very high pressure fluctuations can cause the progression of the optic nerve damage. So
protect the last few nerve fibers.
Of course, of course.
Yeah, great. Well, thank you very much for joining us, Dr. Malyugin. Really appreciate you joining us.
Thank you, my pleasure.